I'm around 4.
Hello, hello. Welcome. And here we are with Dr. Wada. This is Sarah Merritt with Lifestream Health Center. We're located in Bowie, Maryland. And I'm super excited to have Dr. Wada here. And I'll let her introduce herself. But for those of you that don't know me, I'm Sarah Merritt. I'm a anesthesiologist with a practice for chronic pain. We're located in Bowie, Maryland, and we're working to make patient care more, pain care in particular, more caring and accessible, patient-centered and evidence-based. And why I'm super excited to have Dr. Wada here is because she speaks about being a chronic illness patient herself and has so much knowledge around treating patients with chronic illness and the other topic du jour, medical gaslighting. So many things to talk about here.
Thank you so much, Dr. Sarah. I'm so glad we're able to connect again. My name is Kara. I am pediatric and adult trained allergist immunologist, and also did training in lifestyle medicine. And that actually really was and occurred after I kind of recalibrated after my diagnosis with systemic Sjogren's, which was about 4.5 years ago. And at the time, I was only in my second year as an attending physician. I had just come back from maternity leave with my second child. And I thought I was going to be hanging up my stethoscope. I was so burnt out.
Oh, wow.
I was exhausted. And it took essentially the dental hygienist when I went for my checkup to say, hey, your mouth looks really dry. For all the pieces of the puzzle to finally come together. It was like that, that card or the Jenga block you take out of the stack. Yeah. It just kind of, made everything. My eyes have, I haven't been able to wear mascara or contacts for a few years. I did ask my OBGYN about, dryness in other areas. Mm-hmm. I had a lot of body pain and back stiffness that always got better when I was pregnant, which was odd. Mm-hmm. And I had an episode of idiopathic anaphylaxis after having my first child, and had some labs that were kind of off, but not.
Yeah.
I didn't really do anything about it. And I was like, oh, okay. And so I think it's interesting, now thinking about the play-by-play, because I had to gear myself up and give myself a pep talk before I made that appointment with my primary care doctor. Yeah. She was someone I knew, someone I taught with.
And by the way, you're an internal medicine doctor yourself.
Yeah, she was a peer. And she was very kind. She tried to reassure me and said, I guess we can order the labs, but I think you're fine, and everything from her came from a place of caring. And yet how I perceived it at the time still had that element of dismissal. And and my labs happened to be totally wacky of the term bad.
Okay.
And so I'm very oddly thankful for that, because I don't know if I would have continued to pursue evaluation had they been normal, which is that happens in about 40% of patients with Sjogren's.
You could have Sjogren's, you could really meet the diagnostic criteria, but have labs
that are totally normal.
So interesting. Interesting.
So that really made me realize, as I'm seeing patients I work at an academic center. So in allergy immunology at an academic center, we tend to see, sure, bread and butter, runny noses and asthma, chronic hives, which actually tends to be more autoimmune in nature, immune deficiency. But we also end up getting referrals for people that the rest of the team just doesn't know what the heck's going on. And it's kind of that Hail Mary, that they're sending over, can you think about this? Put some fresh eyes. And it was with seeing a lot of those patients that I started recognizing and hearing these stories time and time again of patients not feeling like they had been heard or really listened to. And it was actually through my experiences on the patient side in discussions with other people suffering from invisible illnesses that I learned the term medical gaslighting. I thought, goodness, that nail on the head.
Yes, yes. And so what is medical gaslighting? Let's talk about that for someone who might be watching that either hasn't heard that term or doesn't know what it is. I will tell you that I first became acquainted with it with a friend who was divorcing a spouse, and that was how I became acquainted with, well, what really is gaslighting? And so it was in that scenario, because you could have a functional interpersonal relationship where someone is gaslighting you, but specific type in the medical community.
Yes. So gaslighting, the term comes from a movie back from, I believe it's the 1930s or 40s. It's a movie from a long time ago.
Yeah, and I think it's in black and white.
Yes, and essentially the husband was messing with how bright the gas lamps were, and the wife was trying to be convinced that she was just dreaming it up, that she was going crazy.
Yeah.
And the term doesn't fully, like, if you look at the strict definition, and I'm sure linguists are like, well, is this the right word? But essentially, as patients will describe it, it's going into a medical encounter with a medical professional and feeling like the concerns that you're bringing to that visit are not adequately heard or felt to be seen or validated.
Yeah.
Those concerns are maybe chalked up to a mental health diagnosis or stress, anxiety, weight, those pesky hormones that we may have. And you're kind of sent on your merry way. Or what I see in many cases is the game of hot potato, where folks are passed from specialist to specialist on this attempt to find out what's really wrong, when the reality is we need to take a look at the whole picture as opposed to zooming in.
Yeah. Yeah, I think, for me, it's just that idea that, like, the patient's, whatever subjective report, okay, I feel this, and just being dismissed even, just that dismissal part. And the challenge is that, on the one hand, I see a lot of sides of it, right? Because a lot of times, the physician might be concerned about, well, we don't want to overdiagnose XYZ. We don't want to overtest for ABC. But what about the patient? What about the patient who's got these symptoms, and what are you bringing to them?
Absolutely. And I think, what it all stems down to is a situation where those interpersonal dynamics between the healthcare professional and the patient aren't in a good place. They're either off, the balance is off. There's a, marked difference in power. And those relationships take time and energy to build, and especially to build trust with another human being that has suffered at the hands of the system that they're like seeking help from. And, one of the root causes that I think that's feeding so much into this is when we have a system that just says, let's turn up the speed of the conveyor belt so we can see more patients in less time.
Yes.
You don't have a chance to really create and forge meaningful relationships and trust.
No doubt. No doubt. I would say I'm in a place in my practice where actually now I do have some patients that I've seen for 6 or 7 years, and it's a real blessing. And I have so much more understanding walking into that room and that visit when, like, I know who this person is and their report of XYZ is just in the context of this bigger picture.
Yes. Yeah.
Or my patient who never cancels. This happened this week. My patient who never cancels, canceled 2 appointments. Oh, I just happen to know her mother's in hospice because I've known her for 6 years.
Wow.
But how many of us are blessed to have those relationships? I think it's really challenging. And when you're an academic specialist, hey, we need your opinion. So it may be a lot of new patient, someone you don't know. And you have to forge that quickly.
Yeah.
Forge what you can quickly.
And I think that's what I'm working with our administrators on figuring out how to continue to evolve in
Mhm.
this role and find, a happy medium in, because right now, I don't have as much room for new patients because I am making sure to have that follow up with
Yeah, yeah,
our existing patients. And so, okay, how can we, maybe tweak the system a little bit to allow for, a little bit more balance in that. But
yeah,
that's, that's how it goes.
yeah, yeah. There's just so many dynamics, and I think this is, we're both privileged as like physicians, and also, I don't have a chronic illness, but I'm a consumer of healthcare services, of course.
Yeah.
And how privileged are we to kind of understand all the sides, where really to empathize with our patients as best we can. Like, they just don't have that experience of understanding the conveyor belt or the pressures of the system as it is, and it's challenging, and probably in need of some changes that are going to be a while to get where we need to be.
Yeah. Yeah, I'll never forget. So I had a really bad, we don't know specifically if it was a flare and or suspect there was a supplement I was taking. I ended up with pretty significant liver inflammation and needed a liver biopsy. And
Oh
it
gosh.
was the whole thing. It
Yeah,
was very itchy. It was miserable.
yeah,
Um, but I had my colleagues' cell phone numbers. I had their direct emails.
yeah.
And I still had to pester them, right, to get the care I needed. I felt kind of bad about it, but then I didn't because I was yellow and itchy and felt like crap. Um, but once all the dust settled and I felt better, and thankfully, it was this holy four-letter word moment of
Mm-hmm.
I have so much privilege,
Mm-hmm.
and this is
Yeah.
how much I
How does
struggle.
anybody do this? Yeah. Right. Right.
Yeah,
Yeah. How do you get through it if you're
yeah, so
average
much
person?
privilege.
Yeah.
And then I think part of it also was a little bit of feeling guilty. Okay, how can I now use that privilege in the best way that in the best ways that I can to help others?
No doubt. No doubt. Um, yeah, and hopefully, you know, educating us about your
Yeah.
experiences,
Yeah.
and talking about all of this. And so, what do you think about? I want to touch on gaslighting again.
Yeah.
What do you think about what's going through the clinician's head in those
Mhm.
moments? I wonder, right? Like,
Yeah. Yeah.
you might, if you watch like a patient perspective video on TikTok, for instance, there might be this
Mhm.
one-sided thing
Yeah.
where healthcare provider says something ridiculous and untrue. um,
Yeah.
what's going through that? Why would anyone say that? Or
Yeah.
to assume that these are real anecdotes, these are real things that have happened that
Sure.
get described.
I think it's really fascinating. I have the opportunity to work with medical students, residents, fellows, and work with some colleagues in various administrative and educational roles. And you see these first year medical students, and even third and fourth years, they are so like bright eyed and bushy tailed, and you're like, somehow these folks, end up being the people who are on the other end of those encounters, right? Like those
Mhm.
were those
Yeah,
bright-eyed,
yeah,
bushy-tailed students. Like what happens? I think there's a lot of toxicity in the medical system and in particular in medical education. I think we're starting to see a change in, the in that, but a lot of it still exists. Um, I think the time pressure is huge and burnout. We know over 62% of physicians are clinically burned out. When you're
Mhm.
burned out, you don't lean in, you don't listen, it's really hard to be curious and compassionate. You're checking out, you're pushing away and I can say as someone who was burnt out, every little click on that EMR is like another paper cut that is like,
Yeah.
the death by, 1,000 paper cuts kind of
Mhm.
scenario.
Oh yeah, soul sucking
Yeah, it's like
work that
hurt
you shouldn't have to
people.
do. Hmm.
And then, yeah, so I think those are huge aspects to it.
Yeah,
Um, and just in the lack of time plays into all of that.
yeah. Yeah, and I would say this is where, like, for me, it's come to like just having my own independent practice where I can kind of make my hours, because it's almost like my own like CBT or something. Like if
Yeah.
I'm with a patient and like, okay, you're having this symptom. Well, we don't have to order an MRI right now, but here's the reasons we could, and I might
Yeah.
talk to the patient about a decision
Absolutely.
point like, okay, you've got this, your back pain's worse. We have an MRI on file. It's a little over 2 years old though, so this wouldn't be a bad time to get it,
Yeah.
maybe talking the patient through that clinical decision, especially if it's like kind of one of these, we could order it or we couldn't, and really like having that conversation. And more often than not, it might be a choice to do a diagnostic, but to really talk the patient through, well, here's why we might not do it, but it wouldn't be wrong to do it.
Absolutely. I love harnessing shared decision making. It's this idea of I'm trying to help you step into my shoes, and what's going through my brain, especially, I mean, ideally all the time, but especially like a lot of times there is no one right answer.
Mm-hmm.
It's a lot
Yes,
of shades of gray.
that's right. Yes, and helping patients understand that, and
Yeah, but it takes time.
it
And
does.
that's
Yeah,
the
you've got to.
luxury that I think you and I have been very, and kind of talking about that we've been lucky so far, knock on wood. I haven't had to sacrifice, what I feel like is um, my schedule in a way. Like my department has been so far very understanding and accommodating with
Yes.
creating a schedule that serves me as a human being and my patients as well.
Yes.
Because I've realized that if I don't take care of me, I don't do a good job of taking care of them. And for
Oh,
me,
100%.
that's 2.5 days of clinic a week. And
Say it louder. Yeah. Say
yeah,
like,
that's
if
my
your
happy
clinician
place right
can
now.
only take good care of you if your clinician is in a good
Yeah.
space.
So that's actually the advice I give. Like if a patient is asking like, hey, what should I like, or if I'm talking with a group of patients, like what should I look for, ask about for,
Uh-huh.
referral for, physician, I said, look for someone who's not burnt out. Look
Wow.
for someone
Yeah.
who's happy in their job.
Yeah. And that's not just one practice setting. It's not just academics, or it's not just private
No,
practice. I mean,
it could be
unfortunately,
anywhere.
it could
Yeah,
be in any practice setting,
absolutely.
that you could be burned out or happy.
Mm-hmm. Yeah. Yeah.
Yeah. Because I think there's no, I wish it was simple, like really simple, like that you could, just look for one
Look at
thing.
the Yelp reviews, but we
Yeah.
know that those are not.
Yeah. I think reviews can be helpful. They can be one piece. And yeah, if you find a clinician who has productive relationships with other people, that probably is a good prognostic factor.
Yeah.
But yeah, there's that piece too. Like not everybody is a fit for everybody else, right?
Absolutely.
Yeah. Yeah, that's so interesting. Yeah, I think any of these such interactions, often like a interaction gets described to me where a patient describes feeling very dismissed, or not having diagnostics done when maybe they could have been indicated. These are very often like the thing that precedes them finding a different doctor. Is kind of what I see, and that's probably how it needs to be, right? Like if you're not having a productive relationship.
Yeah, absolutely. I think one of the things that is such a struggle for us too on the physician side, especially thinking about the area that you practice in, are pain doesn't have a lab or a specific number, right? And I would say similar with like fatigue. I mean, there are some scales that you can use, right, with both, but
it's hard to quantify.
Yeah, it's in this in the gray zone, and we know the human brain hates uncertainty. It takes more energy and effort. It takes more ATP, to sort through that. It's more cognitive load, and it also just it doesn't feel as in some ways it's not as satisfying of that quick win that I get in you get a quick win with helping someone go from really stuffy to can breathe again, right? It's like pretty quick and easy. I would think maybe with some of your procedures too, you get some like pretty quick relief.
Some good wins, good quick wins, for sure.
And so what I've realized from my practice too is I have to balance out some of the chronic care with, some of my quick and easy wins too, because that just helps, like it's a quick little refill of my like proverbial cup.
Yes, yes.
Yeah.
And for, I would say I do have patients with significant chronic illness that are recognized and are grateful for like just the being there to walk along beside them, almost like that's therapeutic in some way, right?
Oh my gosh, yeah.
Like we haven't moved the needle a ton, like, hey, I still have a ton of chronic pain, I still have significant disability, but I have certain tools and I have a productive relationship, and that's really like a beautiful thing, and maybe as good as it gets for some folks.
Totally agree.
Yeah. Well, and so I'm thinking about some of the other topics we had discussed. What about medical trauma? So that's like, I think similar.
And there's actually like a new term that has been coined by a group out of Indiana University called clinician associated traumatization. So that's kind of the more academic word for medical gaslighting. What they, what I've taught, and I've talked with Dr. Cullen Halverson. He's one of the researchers of that group. But, what they had talked about amongst themselves when thinking about, they take care of Ehlers-Danlos patients, kind of the area that they're writing and studying about. And so medical trauma, and you can develop post-traumatic stress disorder from medical trauma, is typically an acute event, like a life-threatening type event. Like maybe you had an episode of really bad infection, such as sepsis, where you're in the ICU and on the ventilator and all the tubes and IVs and everything, right? Or something along those lines. But that doesn't describe what happens in some of these, more chronic, invisible, not necessarily less serious diseases. It's just not as acute, right? So it very much is, these situations
dying.
Back to the analogy of death by 1,000 paper cuts, where you're like, oh, it's your depression, it's your anxiety, you're worrying too much, it's your weight. Or sometimes
live with this.
Yeah. You're just a busy mom.
Just like buck up.
And so when they looked at that group of patients, it was somewhere close to nearly 100% of them, if not 100%. I mean, it was like high 90s to 100%. I can't recall specifically, reported that they had interactions with healthcare professionals that were not good.
Yeah.
Not surprising, but
not at all.
Yeah, so that's another term I think that we may continue to hear, because it really is, I think, an accurate way of describing those lived experiences that we hear described often. And if you listen, if you give people time and listen in the space, you hear it.
For sure.
You hear it every day I'm in clinic.
Yes, yes. And how do we start to heal these wounds for everybody, right? Because I think, on the one hand, like, I think truly we're kind of talking about the patient experience of that, and that's the priority. But I've got to think the provider on the other end of that doesn't feel good either, and like our focus should be the patient, but I think it reflects a dysfunction that's there on the part of the provider.
Absolutely. I think you can't have healing one without the other. And the reality is, when you look at trauma literature, the way that we heal trauma, whether it's big T or little t trauma, is through human to human connection and community. And so that's where I think, we do have to lean in as groups, whether it be amongst our, physician groups, as we're, seeing a huge awareness of the benefits of coaching and, true physician and healthcare professional wellness initiatives, not just, the the chair massage and
Yeah.
the
Yeah.
the cup, or something like some branded something gift on, Physician Appreciation Day.
Yeah.
And also, that solidarity amongst the invisible illness communities too. And where I see my role in having a foot in each of those communities, along with several hundred, and I'm sure there's more, but I know of several hundred others that I interact with on a pretty regular basis.
Yeah.
I think that's our role, is to be bridges between
Yes.
those two
Yes.
communities, and to help us realize, yes, help patients realize physicians are humans.
Mm-hmm.
We have human issues, and we hurt. And when we hurt other people, as others do too.
Yeah.
And also to help physicians, reconnect with that moral compass, that we all set out, almost all of us set out to, because there is so much moral injury amongst, our colleagues.
Yes.
Yeah.
Thank you so much. I know Dr. Karawada needs to get moving, and so I'm going to release her, but I feel like we could talk for another hour or so. So I think we just have to stop at that.
Thanks so much. Yeah, if folks want to connect, I'm
a huge fan.
Yes. Yeah, I'm Crunchy Allergist on Instagram.
Yes.
I have a website, drkarawada.com. Kara with a K.
And I think I've got your links here. Website, drkarawada.com. Instagram, Crunchy Allergist, correct?
Yeah. Yeah. And we have a summit coming up, which I have to talk with you about.
Oh, good. Tell me about your summit.
September. So it's the Demystifying Inflammation Summit, geared towards, in particular, moms and families who are dealing with too much inflammation.
Okay.
Modern disease, hallmark of modern diseases, allergies, autoimmunity, cancer, heart disease is excess inflammation. And so we're going to bring in experts to talk about the science, the role of lifestyle and other complementary kind of treatments, and then the mindset we need to take action.
I think that's super exciting. I'm going to put a link to that here too. And awesome. Even as a physician, right? Like, I need a little of inflammation demystified to me, because, how do we measure it? How do we know if we have it? Right? Are there objective measures? I think it's exciting, but I would love to be part of it. And we're finding a lot of success with low dose naltrexone in my practice for what is probably maybe like glial inflammation or something.
Yeah. You've gotten me on board. I have a few patients on it now.
Yeah. It's good, right?
Yeah. So far so good. Yeah.
Mm-hmm.
Yeah.
Yeah. Awesome. It's been impressive. Well, it's so good to have you here. Thank you, Dr. Karawada. I'm a big fan, and I just appreciate you being here.
I appreciate you. Take care. We'll talk soon.
Bye.